Thanks to Breathe, thanks for asking me, thanks to Aware, which I'm very impressed with it as an organisation in its constant reaching out and information and empowerment, and has been very helpful to myself and my own small team at Highfield Healthcare as well in setting up a recent acute adult service. The question, is recovery possible? And is recovery possible without drugs? And why did I pick that? Reid and I were chatting through a few options, and I thought, this comes up all the time, doesn't it? Oh gosh, snap out of it, or oh no, tablets do work, or oh no, don't bother with tablets, that's all psychiatrists are into. And others were saying, gosh, I wish I started that earlier. So it's really, that question. And I'm hoping in the course of this talk and afterwards in our questions and answers that we'll come to some kind of consensus about it that we're comfortable with. Is recovery possible, and is recovery possible without drugs? I'd like to take as much of a scientific view as we can, what is the evidence out there, but the experiential view as well, and the learned experience, and look at that and think, sometimes there are barriers getting to recovery and what that might be. So what do you think? Is recovery from depression possible? Any takers? One yes, yeah. Yeah. So most people thinking yes, yeah. Any qualifiers on the yes? Okay, so there's that query. Is it, yes, it is possible. And somebody says it temporarily. Okay. Is it possible, yeah?
I had bipolar for the best part of 40 years.
Yeah.
And I just think it's getting worse.
Yeah. So that's an important point as well, if somebody has things that are coming back to them over time. Depression will be our main focus. The depression that comes with bipolar, we can chat in the questions and answers a little bit about. There might be a slightly different way or journey or presentation, but we'll talk about that too. So is depression treatable? Is recovery possible without drugs? Yeah, that's a reasonable answer. You're here to find out. Any thoughts? Maybe for some people. Why is the question so often in the news, I wonder? Why do people get so hung up about it, do you think? The way you go to get your blood pressure and somebody gives you a blood pressure tablet and you don't like it and you don't like the side effects, but you don't start attacking the wherewithal generally. You might, but... Yeah, I think the stigma is terribly important in there somewhere. I was thinking, when we're talking about recovery, we're talking about collaborative work, having quality of life, being respected, all the wonderful things that I see around here in St. Patrick's, and I've worked here for many years. So, there is a stigma, isn't there? And, that can often be that somebody can feel guilty because they've taken drugs. Or they might feel weak because they're taking talking therapies. So I think that's something temporarily maybe in stigma. We've shared expertise between us all, and you're experts by experience, many of you, and many of us, all of us in our lives or in our relatives, in our experiences of life, will have a lot of expertise. So I suppose the first question then is, if we're talking about depression here, what is it? And again, you know it very well, but if you think about it, low mood, thoughts, emotions, behaviours, sense of well-being, sadness, anxiety, hopelessness, guilt, worthlessness. It affects your sleep, your appetite, your memory, your concentration, your energy, just loss of pleasure in usual everyday things. Even taking a cup of tea or a walk or a blue sky can leave you untouched. Negative thoughts about oneself, the others and the future, suicidal thoughts, self-harm in severe cases, delusions and hallucinations. So it's pretty miserable. How many symptoms do you need and for how long, do you think, before you're classified as having depression from a medical model point of view?
Any of those for about 2 weeks.
Any of those for about 2 weeks, yeah. So in fact, all you need is 3 symptoms, I think, in the International Classification of Diseases. So particularly, pervasive sadness for 2 weeks with lack of energy and lack of enjoyment. Now, when you think about that, it always strikes me because most people, by the time they present to professional help, will have had the symptoms and the whole conglomerate for a lot longer. Wouldn't you agree? And in fact, I remember in our studies for our exams reading all these statistics, and it struck me in the studies on quality of life that the average age, throughout length of time throughout the world before a person got the appropriate, relevant, individualised help was 10 years for something like depression. Now that is pretty shocking. But people will say to me, oh, wish I had got here first, wish I'd heard that. So I suppose we're about breaking that down. I tell the story of my niece at 10 or 11 in a school just a few years ago. She's 15 now. And she said to me, the teacher told us in whatever the fancy name is for civics class now, that, you can cure this, that and the other, but you can't cure mental illness. Now, I think the teacher was misinformed and may have had experience of thinking in terms of schizophrenia, and even there she was wrong. And of course, my niece put up her hand and said, that's not true, you can. And that's why you have people like my auntie, good child. But actually, they began a discussion, and a few days later, a girl came in who was 9 or 10, and she said, my mum says that Gran got really sad and low when Grandad died. And she didn't eat, and she wouldn't get out of bed, and she was very sad. And she got help, for depression, and now she's really happy again. And interestingly, I said to my niece, I said, well, isn't that fantastic? Good for you. You got that discussion going. And she said, well, I didn't like to think there was any girl in my class whose mum and dad might have been sick, and that would make you feel really bad. But she also said, you need to do more. You need to get the message out there more, because that's a teacher. And it really struck me that obviously I think aware, goal, all of these, and hopefully more in the news, more people chatting. But some people say, oh, I hear somebody chatting and they look glowing with health. I've been in America at an American Psychiatric Association meeting, 49 channels on the television in the hotel room. Every one of them said, I used to be depressed and then I got a Fexor, and they didn't look remotely depressed. So you have all of these kind of things in the ether. But actually, 2 weeks of any of these symptoms, and I suppose what strikes me about depression and why it's so important to get the treatment and to get it right and to get it timely and to have hope of recovery. And even if one relapses, because it's in some cases remitting, that one knows what to do there earlier, and so that one can decrease the suffering as much as possible there and achieve recovery. So it is about knowing the symptoms and signs, and it is about being able to access help, and it is about knowing why at this time. I say to people, why did you get sick right now? Why now? Maybe everything was going fine for 20 years and all of a sudden something terrible happened. Maybe one's eldest child is the same time as something bad happened to oneself, and somehow that clicks. Maybe there isn't any particular reason, but often it's a work stress. Things come together. Why now? So I would say again, if it's our treatments, we'll be thinking of why now? What's combining that here? Can depression ever be normal? Yeah, because, and I suppose when we talk about sort of a medical diagnosable depression, it's you can have it mild to everyday life at times, an adjustment. And in that case, in the stressors, talking to a good friend, exercise, healthy diet and time out works. It's mild, it hasn't hit one's functioning or work or ability of looking at things as much. One can have depressive symptoms in the context of death, in the context of bereavement. I always think we're in such a hurry nowadays, aren't we? Like death, and somehow you're back to work and getting on with it. But loads of cultures say that you grieve for up to a year, Even traumas. People say, oh my God, I have to have a counsellor. But actually, in the first 6 weeks, even to 3 months, you may need solid friends, solid support, community system, church, whatever it is. And after that, if those low feelings are hitting you and coming back and flashbacks, then you may be seeking further help. So I think it's important as well to understand that our mental health through our life will be hit at different times, and it's okay. We're not supersonic, but we need to have a bit of a structure and a framework and a healthy lifestyle in some way that helps us for those moments and times. So you can have part of a psychiatric syndrome, depressive disorder. The distinction is often made on clinical assessment based on the severity and duration, because it is very, very true, isn't it, that there are other times when depression hits and it's not mild. Maybe it's moderate, struggling into work, a little bit harder, decisions a bit more difficult, fearful that phone is going to go and I'm going to have to do something, all of that. And it drags and drags, and if one doesn't treat that, it ends up, is that me? No, affecting one's ability to work, affecting one's ability to function, or one withdraws from people, and that creates its own problems. It's relatively common. We hear all kinds of statistics, and I guess it's about what they're measuring, really. It says 1 in 5 people in their lifetime, others say 1 in 4, others say 1 in 3. Incidence and prevalence rates are rising, according to the World Health Organization, the 4th most important cause of disability worldwide. And that's increasing. And you sort of say, well, okay, why is that? Are we picking it up more? Are there more stresses? They say it's more common in women. I sometimes wonder. I know women may put the name of it, but you wonder, do men often go to alcohol? And it's certainly in my day hospital since November, I've looked and I've got 50% male and female. And I've asked the guys why they're coming. And it's because in the same particular facility, there's also dementia care, old age, a mixture. So nobody thinks you're going into a psychiatric asylum. You know, that stigma. And so they accessed help. So we have to break that down. Sometimes around the country, the very environment that you're going to look for help may not be that impressive when you think less than 6% of the national budget is given to mental health services. Childhood adversities and traumas. Now, this doesn't mean, there's Brown and Harris have done things on that. If you lose a parent before the age of 12, then your subsequent experiences in life of stresses is of loss. Like somebody else might get an ulcer, somebody else might get something else, but the experience of loss. Now, that doesn't mean one isn't functioning and capable, but that stress can hit you as loss. And that's a very painful experience. And, that loss can be a depression feeling. Again, we've a lot, we know now, people coming out more about, sadly, about childhood abuse. And you know that anxiety disorders and depressive symptoms are more common. Again, you would hope that people now have a language. I've had people at 60, 70 and 80 having a language for something that they had actually held inside for a very long time. So again, that can make you susceptible. We all have our own traits of personality, and that's why when I come back to how do we treat it, it's good to know ourselves, to know yourself. As I always keep saying, your greatest strength is your greatest weakness. If I'm a little bit obsessional, so I have to get this sorted and that sorted and the other, I can be very good at work, can be very good if I'm a detective, can be very good if I'm working forensic. But if I have then something bad happen to me, I then begin to have these safety behaviours, or I overdo it, or I'm a housebound housewife and I have to have everything right. And unless it is right, I beat myself up. So it's very important to understand that makeup, because that makeup, which is criticising yourself for not getting the detail right, can perpetuate a depression, can maintain it, and can leave you ready for a hit, because when something happens outside of our control, which does in life, it goes right back in. So it's really useful, I think, and I think the kids nowadays, I hope, are getting more education around knowing themselves. More common, they said single, divorced or widowed. I was thinking what was left, but then, it's married. I think married men, they say, are more stable from a mental health depression point of view, and it seems to be the idea of having a confidant. Now, what I would say is what's important there is to have a confidant. In other words, somebody emotionally that one confides in. And it may not be a spouse, it may be a very good friend, but there's a huge amount of literature on the preventive aspect of being able to have a safe emotional outlet. Often associated with physical illness, disability and substance misuse, which we go on. Okay. So what does recovery mean? I asked a group just last week in my own clinic, and, getting back to where you were when life was good, having proper quality of life where I can enjoy things, getting back to the word hope instead of despair. feeling naturally happy instead of forcing it, accepting what's happening to me. Now that last one is really interesting, isn't it? Accepting what's happening. Acceptance and commitment therapy, it's a psychological therapy which is of benefit in depression. And, it's easier said than done, radical acceptance. It's easier said than done to accept where I am now. It's easier said than done to let things go. But with good psychotherapy, that can be helped step by step. Just to say, because I always think, people's experience is the most powerful. And I have a young girl who's 24, so she's doing well, and she said, I can use this. But she wrote about, her last bout of depression. And then it's like, I've done this now. I've spent 8 days in bed, not washing, not eating, not speaking, trying my hardest not to think or feel or move in case I woke it up. Reminded I'm here to be tormented. That's here, in this place, together. Sometimes I want to stop climbing, free fall to the bottom, curl up fetal position. I suck my thumb. I try to erase everything, all the good with all the bad, the love, the hate, the sadness and the pain. I wake up for a moment, I almost see something for a second, and then it slips away. Alone, I'm unwashed and uncaring. And, anybody who's experienced depression can kind of think, this girl is really suffering there. I used to try hard to get better. I had friends and families who loved me, who did their best. Anyway, she ended up seeing a doctor who looked her in the eye, explained my illness, told me there was hope. An expert team. We changed my meds. I began this process called recovery. I was so sceptical. Sceptical about group work, sceptical about mindfulness, very sceptical about art. Honestly, I was sceptical that this group of people could help me, but it was sinking, so it was a lifeline. 4 weeks later, I'm beginning to feel like myself again. All my real history of depression, I've relapsed and come through the other side several times, but I've never before felt like I had ammunition to help me fight it. Next time, to understand what has happened inside my head. That learn to take care of my own mental health, learn what affects me badly, what's good, be mindful, not to believe everything I think. And that's very powerful in cognitive behaviour therapy and other therapies, that your thinking doesn't mean an action, not to believe everything I think. I learned how to be mindful. How do I bring myself back from negative spiralling thoughts? I've learned not to believe everything I think. I've learned that work and maintenance is required to stay well. There's no one size fits all or no magic pill. Now, she does need meds, she takes meds, but she said you need to be the expert on your own mental health. It's important that people teach, don't tell, listen and don't judge. Anyway, on the day she discharged, she sent me this note which says, mindfulness works, I love art, I am able to say what I feel. I'm allowed to feel what I feel. I can change. I can have balance. I'm a work in progress. And that's okay. Now, I think that, and she has been doing well, because when any kind of relapse or stressor starts, she'll actually recognise it and use the techniques that she learnt. And that's terribly important. And I think it's powerful, because otherwise you could have somebody says relapse, relapse, relapse. And really depression, when you don't get those tools, leaves you with a sense of helplessness. I don't know how many of you have read Seligman, Authentic Happiness. This is all the airports. But he wrote 30 or something, 40 years ago on authentic, on depression as a sense of trapped feeling. And he had some poor animals in this little box, and they had to jump up and down through a glass thing to get out, but they hit their head off the glass thing and were electrocuted, these horrible experiments. But anyway, these particular animals got terribly depressed after jump and fall, and they gave up. So he wrote all about depression as being trapped helplessness. And that's true. You can get helpless, caught. As this girl who wrote that testimony said to me, people were always saying, get out for a walk, but when you can't get out of the bed, that's the first bit, you hate yourself. So you're trapped and you're helpless. But the actual psychologist who studied those animals went back 30 years later to look at the ones, 30%, who actually, when the glass was eventually moved, they jumped out anyway. So they never gave up hope. What was that extra factor? And he began to look at resilience factors. which we do now a lot through the recovery movement. And actually, it's important not to lose sight of your resilience. Because, as I said, if you or your relative or your loved one, has got this far, and it's very important to instill hope and to actually, where does that hope come from and what it's about, and hope in recovery, because hope is a terribly important thing. So a medication can make you feel better, but there's a whole understanding of depression and its effect on you, and there's a whole understanding of the road to recovery to maintain that hope. I'm able to function like before, looking forward, not backward. Excuse me for the way that jumped in. I have a new PowerPoint thing and I haven't quite got the hang of it versus my old-fashioned one. Gosh, that's a bit tiny. Some of them said as well, hope is vital. If you haven't got it, you need to turn to the professionals. It's all you do to do with hope, to have confidence in the future that things will get better. With the right tools, recovery is possible. Stop beating yourself up. Knowing how to access the tools, where is help available? Because lots of people find that difficult. Somebody said, so-and-so wrote me a prescription. Mind you, I've had GPs who said, I tried to talk, and then people get disappointed who don't have a prescription, so it's kind of both. There's support out there, but there have to be signposts, and we all believe in recovery, that's why we're here. I told a medical colleague I needed to see a psychiatrist, and they just laughed at me. And I don't think the laughter is cruelty. Sometimes it's stigma, sometimes it's defence, sometimes I might have that too. Sometimes it's just fear. And, and I think it is possible to have recovery, but there are these blocks along the way that can undermine a person. So, is recovery possible without medication? So for some people, this was the focus group last week, for some people, yes, but it takes longer. It takes years instead of months. Don't quite agree with that, but that is that person's experience. Medication gets you to a place, like a crutch, where you're stronger. And I think that's important. I'm terribly pragmatic and practical, and I'm saying to somebody, well, if you're not eating and you're not sleeping and you're agitated, if something helps calm that down so that you sleep, that's restorative. If something helps get your appetite back, that'll keep your strength up. If something helps get the agitation settling, and then work on the others. So I'm terribly pragmatic, but I'll show some of the research that says, yeah, it works, but not for everybody. Kind of mild exercise, friends, will work. Moderate meds or talking therapy, or a bit stronger, more, with a combination of both. For severe, very severe, you can't lift out, you can't eat, you can't drink, you're lying in bed, there's nothing. You do need medication, and then work when you get going a little bit, get work on the others. That would be kind of the ballpark. You think you're getting worse when you take the medication, but it's all about trust, and it does get better. Now, I'll come back to that later, because trust is actually a very interesting one. And, trust is it all in the mind. When a person is depressed, it affects your thinking and your relationships in your life. So you're not inclined to open up to somebody that you don't trust. And some people like somebody who's a bit distant, and other people like somebody who's evidently expressive and emotional. But you have to have the trust. And that's an interesting one, because if you don't have trust, it's much less likely to work. And there's lots of studies on that, both placebo effect and actual drugs, that the trust makes a difference, which is really interesting. Time changes things if you believe it's possible. I had one gentleman a couple of years ago here, young man, 27, social anxiety. And we know social anxiety, which got him depressed, can affect you as a boy, 14, 15, 16. It'll really affect your lifestyle and friendships and so on. It also affected his job. He just couldn't give a presentation. It'd just be a blubbering mess. Did loads of CBT. Didn't work. Exposed himself to it, which normally would, calm down, etc. Just agony. And I remember listening to him, and I was thinking, already at 27 or 20, whatever he was, he'd married, he dealt with really serious things in his family on both sides. So I thought, this guy, he's a real coper. He's really resilient. There's something else going on that means he gets this complete nervous attack. And then I was asking about his family, and it used to happen to his dad. And in his case, I went ahead for one of the SSRIs that are licensed for social anxiety. 6 weeks later, he was a new person. And like he'd been trying for ages. So he was a real example to me how you have to take the individual story, the individual person, and work with that. I know what I should do, and I don't do it. Overwhelming everything you're told to do, and you can get more confused. So professionals can help you to break it down. And I would have a great belief in the use of an occupational therapist who is mentally health trained. Why? Because they just look at function. They look at your work. They look at the work stress, or they look at home, and they break it down into goals. And the goals can be, today I am going to get up and have a shower, and I'll feel fantastic because I've done it. And it's the first time I've got a sense of mastery in a long time. And they'll break down things into component external parts, and it begins to get past that trapped helplessness I'm talking about. It's good to know you're not alone, the weirdo in the corner. So recovery also, just things like groups like Aware, but I've been mesmerised as well by the power of people in a safe group being able to share without having to explain. And that really in itself decreases a whole load of stress. Because an awful lot of times you're explaining something to somebody who, and everybody has an opinion, don't they? Don't everybody has an opinion on whether you should have drugs, you shouldn't have talk in therapy, what it is, and some of them are good, but some of them are kind of useless. Because if you're beating yourself up and somebody else says, come on, forget about it. My first exposure and interest in suicide was a young medical student many moons ago when I was in Galway training. And I remember treating him as an intern, and he was on his second go of paraquat overdose and sadly died. And I'll never forget the tragedy of it, because he was the class clown. Everybody found him a fun guy. But, when you're talking to somebody and they say, well, the more they try, the more people say, come on, bit of crack. So the idea of finding people who will listen and give you a space where you don't have to put layers of pretense, that will actually also help, because we're mind and we're body and we're spirit. So depression, we said, was common. Lifetime 30, and I think it's more, to be honest. Treatment with antidepressants have shown a third of people get to complete remission, a third show partial, and a third fail to respond. What should you do, or what should I do in that case? Now again, a third of people get to complete remission. That sounds little, but there are other things then beside the drugs that are part of the treatment. So somebody in the audience said partial. Remission doesn't mean necessarily totally better. It might mean 50% of the horrible symptoms are gone and I can work on the rest. And a third fail to respond. Why is that? So we have to have something besides drugs, because drugs alone don't work. They're modifiable things: drugs, alcohol, domestic violence, childcare, financial, activation exercises, having the courage to make a change. So I thought I'd spend a few minutes just flying through this because I know it'll probably be up on the Aware website, will it, Bridge? Yeah. So people can look up the references I've given if they wish. But basically in the American Journal of Psychiatry, they looked at outcomes for, say, a common antidepressant, Cipramil or Ciprigor, citalopram, for depression, using measurements based on this huge trial of thousands of people called the STAR-D trial, which has stood the test of time for giving us, as doctors, a kind of a to-do pro forma that we should follow. In other words, stay on something, try it, but only try it, stay on it long enough to see does it work, but don't stay on it and keep adding regardless. You can switch to something else from the same class or another, or you can add on something. And what are the steps in which we do that? And does it work or not? So that will be on the website, as I said. But basically they had 2,876 people, and 75 had recurrent depression, and 15 years was the mean one. So there were mean length of illness. So it wasn't an easy episode of depression we're talking about. So remission, getting rid of all the symptoms, just about 30%. The time took 6.7 weeks. Time to response was that. So you'll often find a psychiatrist saying, look, these things can take up to 6 weeks. I know there's some medications, because they give you sleep or because they give you an appetite, you begin to feel better a little bit sooner because you've got a bit of hope. But actually, it is important to give them the time, because you might only get the side effects at the beginning, whereas actually you want them to go into the brain, so to speak. Insofar as we understand how they work, and physiologically, I have said, I stand over the fact that they do work, but they don't work in every case. That looks slow. And again, that'll be on the website, but if you think about it, that was Cipromal, but like 28% it worked, but if they were failed, some people switched. 727 switched. Bupropion is Zyban. You know, it's used for stopping smoking sometimes, and it helps with anxiety. But again, I'd only do that with a doctor because some people get very edgy. But 21% further helped. Venlafaxine effects are 24% more. So you had the 28 who responded and a further. So you're up to half when they move to a second one. Sertraline, which is Lustral, bupropion. I thought we added, oh yes, that was to add it. That was instead. That was to add it. Or Buspirone. So if you see that one thing which could take 6 weeks and work but not work, then you either switch or augment, add in something. So you're up to about 50% there. And then moving up here, mirtazapine and further 12% added in. I think some people know mirtazapine and venlafaxine, which is called the Californian cocktail. Boosts appetite, can be very helpful. Nortriptyline, which is the old-fashioned tricyclics, it's like a gold standard, but you get things like constipation and dry mouth, but then you don't get racing thoughts and flying head as you do in some of the SSRIs. So lithium, lovely medication, even though it's a natural salt and you have to watch it for thyroid and watch it for loads of things. However, tried and tested, it's protective in the brain, and that adds another 15%. T3, only 24% would help, but that's thyroid hormone. In the cases where they failed, they moved on another 58 and 51, and they got a further amount of people. That's the Californian cocktail. Tranylcypromine, the old-fashioned MAOIs, where you have to, not so many people like them. They kind of reverse when people have kind of reversed symptoms, like they're oversleeping and, you know, and all of that kind of thing, and a lot of anxiety, rather than lack of sleep or early morning awakening. So I suppose what the STAR-D trial said was that stay on it, stay on the darn thing long enough, follow it. There will be side effects. You can see that even after 3 months you could have just 50% of people. Isn't great, but it is something. The main message is, and I remember Pat McKeown used to say this all the time, you keep at it steadily, using one class or another, listening to your patient, looking at it, trying. And people used to say years ago when he mixed and matched stuff, oh no, you should only have one. Now they're saying it's okay, add in and augment because there can be differences. But keep at it until you eventually get something. And for some people, they prefer that route. I think that if you're going to stay well, maintain wellness and try to prevent relapse, that's where tools come in that are terribly important, that are non-drug treatments. Okay, now obviously people say, oh, I feel great now and I'm off the medication. In general, I take a lot of people off, but only, and leave them on a year for if they're on it for the first 9 months to a year for the first episode. If they had a recurrence twice, I think about it very carefully, because a lot of research says dose gets you better, keeps you better. So again, thinking about that. I would put in a lot of psychological and other therapies and build a person up and have their resilience and then come off something gradually. And people can do very well. So accessing tools. Evidence-based for the non-drug, right? The non-drug. Everybody probably knows about CBT nowadays. Would it be right? People talk about, the connection between your thoughts, your behaviours, your actions. Very well shown to work for depression, anxiety disorders. Doesn't suit everybody. Interestingly, there are developments now of it that add on some psychoanalysis like schema therapy, and I find that very good. I went more the interpersonal psychotherapy route, which again, the NICE guidelines in England, which look at evidence-based for treatment of depression, recommend 3 psychological therapies as having a good evidence base. In other words, they've researched to show that they're effective. And that's behavioural activation or CBT or interpersonal psychotherapy. And I think why I went the interpersonal psychotherapy route is I'd often find some of my patients were so emotionally upset you couldn't be thinking what you're thinking or identify your thoughts or wonder what it is. And I often thought, gosh, I think that'll be more my personality. It'll all be going on in my head. But some people with the CBT can actually sit down, like the homework, work with somebody and think, what is it that I'm thinking? What's the negative what's the automatic thought? And behavioural activation I'll show you now. But again, very interesting, because behavioural activation, if somebody in the first couple of weeks of an admission to an acute hospital for depression has behavioural activation as a therapy, they've been shown to cut the time to recovery by half. I mean, it's very powerful, and yet it's a very simple intervention. There are also home-based psychological interventions. Everybody knows mindfulness, and they say, gosh, is this going to be like the Valium of the 80s? Or is it definitely going to work? And I have a lovely registrar who just left for the Wonders of Australia, gave me a book, Mindfulness, 25 Ways to Live in the Moment Through Art. And I was thinking, well, you could only be in a beautiful form by looking at beautiful art mindfully. And mindfulness being in that moment, because when you're depressed, what are you doing? You're ruminating the whole time, over and over and over and over. Who was it said, the mind can make a hell of a heaven and a hell and a heaven of a hell. Bibliotherapy, I'll give you a little bit of the background research for nature, role of the environment, creative arts, music. So behavioural activation. Does anybody know what behavioural activation is? Or hazard a guess? It's not even change your behaviour, which is interesting. It's actually literally activating yourself to do something. And it's adaptable. It's very, very simple and straightforward. And there's a brief version about it. And basically, the concept is, like, when your life events, less reward out of life, you're sad, you're tired, worthless, indifferent. So what do? Your behaviours. You stay in bed, you stay at home, watch TV, withdraw, ruminate. So what happens as a result of that? You lose friendships, conflicts, supervisors at work, financial, and it all builds up. So that's the way it conceptualizes depression. And so what you're doing then is really simple, but it helps, which is a bit like I'm saying is, a simple activation chart. How do I build up gradually my activity? I get a sense of control back over my life. So I say I might have somebody and they literally have a shower, or they make a cup of tea, and that's all they were to do at that time, and then walk the dog. How was my mood? And you begin to link, well, my mood was sad, but actually with that I felt a bit better, or with this situation I got a sense of achieving something. It's the first time in months, and you build it up gradually, and just 2 to 3 weeks of that. Big group in Oxford studying behavioural activation. Very, very simple, but very effective in breaking this trapped, helpless cycle that people get into. So increasing pleasant events and the behavioural component of CBT. And again, there are the research papers if anybody wants to look at it. Very interesting group in Oxford studying it as well. And it's standalone, it can work. The OTs, occupational functioning. Then again, the model of depression based on learning theory. People become depressed. Again, it's avoid and escape. We avoid and we escape things. Thanks a million, Ron. Then, so, like, people will say, they remember, like if they remember their mother lying in bed or their father lying in bed. So it becomes trapped. You think, oh my God, that's what depression is. I go to bed. And it's very hard not to go to bed if that's the model in your head. We learn things. But actually getting out and activating and doing something stops that helplessness taking over psychologically. And so you feel a bit more in control and better. So avoiding those kind of passive behaviours. Sleep, like watching daytime TV, feeling more tired, partner criticises. Did interpersonal therapy and behavioural activation with somebody, and it just broke the cycle because there was this conflict all the time with the partner. I came home and found her lying there looking at the television. Ruminating why that's happening. Going back, I feel such a loser. I feel more depressed, I feel more ashamed. I comfort eat, then I feel bad. But when you break them down and saying these are the things, these are the behaviours that get me more withdrawn and down, that help, and nothing changes and I get annoyed with myself, and you begin to recognise that experience of feeling depressed and break it down, not all at once, but by those small diaries, bit by bit. Activity scheduling. Short-term goals. So somebody said, well, I'm a terrible parent, and I've withdrawn. and I can't, and I feel so bad and I feel so guilty. But actually the only intervention might be to read that book with that child on a Saturday night. End of story. And begin to build up again the sense of competence and that I am an okay parent. Mightn't be a great one, but I'm okay. Cognitive, the rumination. And I think the rumination and the self-attack. We have to instead turn why or if only questions into how. How can I be a bit better here? How can I move this? Because rumination, depression, negative thoughts of myself, the past and the future. And that's all that happens physiologically. When you get out of depression, you say, well, actually there were sunny days as well. And yeah, Dad wasn't great, but he wasn't up bad, and there were better days. But depression catches the rumination and it goes into the negative triad of oneself, the past and the future. And it's good to understand it and to know it, because if you beat yourself up or ruminate or get stuck in it. So there are ways of avoiding rumination, and I'll come back to that in a little while, including, forest therapy and nature. Not because we're all tree huggers, some people maybe, but because when you reach something that rests your mind, that's bigger than yourself, that breaks that rumination, rather than turning in and round for a little while, having the experience of a mind that's not ruminating negatively, looking at something bigger. Mood logs. CBT, for people will be experienced again, Beck, who I met, a fabulous guy, he's well into his 80s now, and he was already 50-something when he thought to look at the group of psychoanalysis he was looking at and think, there's not good outcomes here. And realising that people who weren't in that particular negative analytical group were doing better. And then he began to look at CBT. He's a very interesting man. So we look at, it's collaborative, it's active, it's open-ended questions, it's very structured, very focused, 16 sessions. Like if I have a thought I might crash, my mood will be anxious, my feelings, and I'll just want reassurance, and my heart will rate and go round and round and round. CBT therapists, you'll notice, don't particularly like to reassure you because it keeps going back and forth. They'll be like, frustratingly, what do you think, or how do you think you might approach it, or how do you think you might look at this? But just breaking that cycle. I had a lady yesterday, she had panic for about 2 years and real depression. But actually we went into thinking the feelings she's thinking. What are the thoughts? And she began to have a panic just having those thoughts. She said, I do it for myself. And she began to realise you can begin to break that cycle. By breathing, you can break the cycle by the thoughts, you can break the cycle looking at the feeling. So depression is trapped. Anger, for example, I've been disrespected, it's unfair, I won't stand for it. Sometimes people get depressed in bullying situations, in work situations, and our intervention might be, tablet's not going to do it, but actually might be to help the person be quietly assertive. I think one particular person said to me the other day in the clinic, and I thought it was so interesting, because she had been really put down in something and really made to feel tiny in front of others. But she just asked the person into the room and said, do you realise what you've actually just done out there? And I thought it was great, because sometimes you might say, well, what have I done? I have to stand up, I have to say it. Do you realise what you've just said? Do you realise what you've just done? Putting it assertively back to the person for them to reflect on that. Very interesting to put those boundaries, because anger, frustration is when the anger doesn't have a focus, and it turns in and you get depressed, and it can move from anger, fear, depression, guilt, and they're all destructive emotions that maintain a depression. So again, we can look at those through CBT and begin to say, well, look, this is a bit of homework to do. Let's challenge it. Maybe not in, the guy who's really assertive there, but this other situation, this friend is always taking you for granted, or what you might do. And how do you feel after that? And identifying negative automatic thoughts. I love the word NATs, because it takes a while for you to know what is it that's maintaining a depression. And it can be that you never allow yourself to feel that you're good at something. A mum will go into a room and see the clothes on the floor and think, I'm a terrible mother, he's never tidying. Another one will go in and say, oh my God, that child is the messiest in the city. And it's, your negative might be, I'm never good enough, because this internal little schema is telling you since early on, oh, bad boy, bad girl. And we identify those and begin to get the shift then in mood, distinguish between the thoughts and emotions. And images, you might be in a situation, be very defensive, very reactive. But actually, in studying it and looking at it from a psychological point of view, in your head, you might be back in that same situation where it ever first happened. And did you feel terrible? But this is a different situation. So you begin to shift, move away from that personalised image. So the model of depression for cognitive is I'm bad, useless, unlovable, the world, the future. It's always like this, nothing can do, nothing will make any difference. I'm breaking that down over the 15 or 16 sessions. CBT works through self-help books. I give lots of people bibliotherapy. I worked in Northside when we had a thing on the public libraries. We were allowed to actually prescribe a book, which was fantastic. And, it can really help and give people a whole way, tools to look at their self-help. Some people like the computerized CBTs. Mind over mood and all of those, psychoeducation, disorder-specific, individual formulation-based. Again, they're all bibliographies that if somebody wants to look them up, treatment plans, anxiety disorders, mind over mood, and the research on them. IPT, that's the one, have formed a network in Ireland. It's more developed in England. They're training thousands of therapists in interpersonal therapy through primary care. But we formed a network north and south here to try and get people trained up in it. Lots of people have done courses but are not accredited fully yet. It works on attachments and focal areas. In other words, we all form our attachments in life early on. And you might have an idea of a parent as a protector. You might have an idea of a parent as an aggressor. You might have, an experience of a sibling, as a positive. You might have it the opposite. So again, we specify the problem in ways that looks at solutions. And depression can often be around grief, transitions in life. We've so many transitions, don't we? Be it childbirth, menopause, be it life, retirement, be it, people can get periods where they get what I call promoted above the level of one's own success. Always be careful of one's own ability. Always be careful to know what you're good at and not to want to just keep striving for something that may not suit your personality at all. So disputes, conflict, some very, very funny ones, aren't they, on the Irish. Like, I hate going in and asking for a refund, so you can imagine what we're like in conflict. We'll put up with something. But actually, interpersonal therapy looks at these areas and connects the symptoms in those setups to mood and gives a person communication skills or ways of managing them or ways of approaching them that actually give them a new skill and a new lease of life in that. And that I have seen lots of times in people who've been treated for depression, in and out of hospital. Yes, had meds, but it fell right back in because perhaps there was still that unresolved conflict at home. There was still that sensitivity. I remember, one case, and she always says I can use it. Mary, I can call her. But actually, we were in session 5, and I realised she blamed herself. She blamed herself, and nobody had ever thought it for the death of somebody in her family because she thought she was cruel to them. She'd only lost her temper once. But everybody else in the family, she'd always been the good girl and never done it. But she actually did. And it was this trapped guilt in a very dysfunctional family. And what did I do? Spend 3 or 4 sessions saying, you've got to talk to X in the family. And did. And it gave a whole different perspective because somebody had looked at it and experienced it as well, but from a different angle. She hasn't needed hospital since, and she used to spend 6 months there. Of course she needed some meds. So we're powerful beings, really. So interpersonal therapy for depression. Sorry, I won't keep you. I'll fly through some of that. So there's a theory about it. That's Harry Stack Sullivan, an Irishman actually, who looks at all attachment theories and Bowlby and all that, how we are in attachments, what loss hits us like, what's depression like, how we view ourselves in it, and communication. If we learn communication, it can really, really help, because I find that many times people don't even have the emotion for what it is they're experiencing. And I might have to say and reflect back, are you happy? Are you sad? How do you feel? What's this? And untrap things. Distress. So we build on relationships. It's not about the therapist relationship, it's about the relationship of the patient with others, and we build that up. So, time's up, I'm through listening. Now, I'm a little bit more to go, but in that one I wanted to say is that sometimes people will say, I'm in counselling. And I always say, well, what kind? Because if it's supportive, that's fine. But it's the same as a good friend. It's supportive. It's not going to change the negative triad if that is negative thoughts about oneself and the past and the future and the ruminations that's keeping the depression going. That is going to need an evidence-based psychotherapy like CBT or behavioural activation or the actual interpersonal therapy. So it's very important. You know, I always say to people, you're too important, and your mind and your soul and your heart is too important to be just going to something that you're not convinced has a benefit. And, so again, it can be animal. Running on to the last few minutes, nature and the role of the environment. Does anybody here think that nature has a role in recovery? And what would you say would be the benefit of nature? It engages the mind, yeah, it does. It engages the mind, yeah, that's it, isn't it? That's really it. It engages the mind. And looking out, when you're depression, you're looking in. It does. Now, it may, not for everybody, not for everybody, but for a lot of people, the environment has a powerful role. If something's dark, I often say to people, I've worked in so many different facilities. This is nice and bright here. But I've worked in so many mental health facilities that I just get depressed sitting in them, because it's just dour and disrespectful. And of course, I think it is terribly important that the environment and architecture and space gives us a sense of dignity and a sense of being worth thing. Person and environment. The importance of an individual. Again, that's the research behind it. For those who want to look it up, it comes from systems theory, how we are in the middle of it. Like looking at the two, which of them is more relaxing for you? And most people would say here, and I think it is. I know when I saw it first, and the social worker who's a forest therapist who works with me, fabulous person, but she was saying, I said, I love the lights. I love lights in the evening. And, in the city, I love the lights in the Liffey. I love lights in the cars. And I'm obviously in a sense of denial. If I'm in the middle of it, I find some way of finding something nice about it. She said, there's always one. 99% of people prefer the other one. So I said, no, I do prefer it. But it's certainly that would make you feel more crowded. And I remember when I was doing the physiology of stress years ago as a lecturer, looking at the blood pressure of people who were stuck in a traffic jam or at a red light. And it was much higher than going to Mount Everest. The noradrenaline was pumping out of them. The bad stress was flying out of their saliva. Like I'd say, I wouldn't even have to ask somebody how they're feeling. I'd say, spit in there and there'd be bad stress. Lots of it. It's amazing. It just pours out of your body. So we do need it. That systems theory, determinants of health, where we are, our streets, our transport, our culture, our natural environment. Now, my Shirley, who works with me, she has done a master's in a study on restorative effects of it, social contact, physical activity, the restorative aspect itself. And, we express spiritual things through religion, nature, art, connect with nature, something greater than ourselves. Awe. The children, they just, that's awesome. They just love something bigger than ourselves. That relief, that wonder, getting beyond something, that transcendence. There are people who have green gyms. I mean, we have work around something like particular walks and what you'd look at and where it would. And Dublin has a lot of nice places actually like that. Ecotherapy, healing gardens, all of these. And the evidence around it, there's a RCT for that, randomised controlled trial, reduces rumination, seems to be the constant. So whatever else you can say about it, it seems to reduce that ruminative negative going round and round and round, getting a bit of relief of that. Because rumination is associated with depression and anxiety. And either they block or counteract that rumination. So I think that's very, very useful. Lee et al. Had a randomized control study around negative mood states, because you know that the adrenaline is with, fight and flight and go, and the opposite, which is parasympathetic, is the relaxing, calming, blood going to the periphery, heart coming down, deeper breathing. That's the opposite system that goes there. So again, there's plenty, and social connections. Now, believe it or not, there are groups in Ireland. I think if you Google Forest Therapy Ireland, there's a group on the south side that you can join, and they're looking for volunteers for some of their depression work. Quilcha, Environment Protection Agency. Exeter has a dose of nature research, which is, she went over. Healthy parks, healthy people. We haven't got to the stage of green prescriptions, but maybe somebody will talk to Simon Harris or talk about it. In dementia care, 30% of people get depression. And people think, oh, that's normal. You'd be a bit depressed if you're in that. It's very important to notice if somebody is irritable or not sleeping or not eating or low or all that. It's depression, same as anybody else, and to treat it. And so in that one, which again, you'll get it on the website later and move into it from YouTube, that shows one of the examples of the power of music in managing depression, because there's a lady who hasn't spoken very much, and I've used music quite a bit, and just somebody has this familiar song and you see her hands begin to tap. And if you look at music in a setting, people start to tap and they start to link, they start to look at each other, and you're automatically connecting with in all the non-verbal ways. And then she begins to sing, and then she begins to laugh. And that laughter can be a huge relief. So music is very powerful, and it's very powerful, I find, in a positive, to watch other way, for people who may have had traumas, and you use good positive reminiscence for music, because music is moving into a non-cognitive side of the brain. In other words, you're not stretching to think. It's instinctive in what it's touching in you, good and bad. And that idea of being able to tap. I had a lady with real severe depression, frontotemporal changes, couldn't rationalise anything. Beats, drums, all of that just lifted her spirits hugely. Okay, so apologies for that, not being able to work here. So creative arts, bibliotherapy, mood diaries. So I suppose at the end of it all, the treatment for depression is recovery possible. They say, yeah, in mild, use anything. In moderate, you could use meds or CBT. Moving up to about 60, 70% if you combine them. If you bring the social things in, like nature, art, all of those things, that moves it up to 95 to 99. And there are very, very good results coming there. So I suppose it's whatever metric you use, like it's recovery. It's remission of your symptoms. Personal recovery. Am I optimistic again? Have I meaning in my life? Am I part, or have I belong? Do I connect? All of that kind of thing. And I mean, I think a bit like my pal here saying it. I was the one, it says, I had a niggling, whispering, picking me apart mind, which was telling me lies. That was the thing. I was tricked by my own mind. But she says, here I am now, and it's okay. I'm just one piece of the puzzle. I can have balance. I can take control of my thoughts and emotions. I am allowed to feel what I feel. I can now say things I never would before. All the love in the world and every self-help book on the shelf wouldn't have gotten me to where I am now. So I want to say thank you, because I needed that team to help me understand myself and unlearn bad habits. And I think, again, it's sort of powerful when you think that and I think it's never too late. Like I think 65, 70, 75, we can learn things we didn't know before and actually get a greater quality of life. Is recovery possible without drugs? Yes, but I would say whatever works best for you, because, sometimes a person responds very, very well with drugs and is up and gone. But I would say is try and prevent relapse and help. The best evidence we know. Relapse can also be prevented using non-pharmacological interventions. So it's a shared journey. That's that testimonial. It's okay to take medications. It's okay to need help. It's okay not to be okay. Anybody know what that is?
She's well on the right side.
Yeah. Yeah, that's interesting. Yeah, it's true. You're thinking of the left over here because, in fact, it was 16 different people making it. 8 people had active psychotic mental illness and depressed, and 8 of them were homeless and had difficulties socially. But you're thinking of the left, is that the second up or something? But that's interesting because that's the one I picked up when she was doing it, and I was thinking, oh, she's missing something, and I said it was that part of the brain, and I checked it out, and it was a temporal lobe epilepsy that was giving her psychosis, and she got cured with an anti-epileptic. She'd been years and so well spotted. Yeah. So that was a joint project in my very first year of studies as a trainee in psychiatry by down in Mayo and Mayo Arts, Creative Arts, and I had a very good psychotherapist, psychiatrist, who let me go and do all crazy things at a time when you could ask for money from the local health board and they gave it to you. So I got 2 Italian artists to come and work with 8 people in a rural community. Why I like it, it's Greek mask. Greeks, as I understand it, in their theatre would show their moods behind masks, and you spoke out through it. So people were very non-threatened in doing this for the whole week. But at the end of it, I had one gentleman who, for the previous 15 years, needed a nurse to call to get him out of bed. He had negative symptoms of schizophrenia. His depression was quite constant with regard to the apathy and amotivation. But he participated in this for the week. We collected and brought him in. So he gave us a ring on the Friday when we were having a end-of-week presentation of this to Claremorris Town Hall, and people came along, and it was fun. But he rang and he said, could the nurse collect him? He wanted to buy a new suit. And he took a picture beside it, and he made eye contact. And it was one of my happiest memories, because I thought there was something in the activation, in the togetherness, in the doing that overcame that apathy. And it consistently continued. So art therapy was very, very big for him. So connectedness. What connects us to other people? What gives us hope when we're ill? We're vulnerable when we're ill. Awareness of ourself, awareness of others. What's the connection? Music gives you connection. Being together, understood, can give a connection. You can still be your own independent self. You don't have to be all chatty or all anything. Just belong in some way. That's the placebo effect I talked about. That, I think the power of relationship is terribly important. Yeah. And a tool that blends, our science and our art together, And I think if we're empathic and connect, have shared decision-making, shared emotional space. And I think that connection, where sometimes somebody else is the powerful other for a while in the relationship, but it's still collaborative, and that gives hope. That's a real picture from a trip in Eastern Europe. And I was thinking, my own great-grandmother family, they walked for miles like the current refugees. My grandmother was born just after arriving here. And I like going back there to think, well, thanks be to God we got out of there, because the people who stayed behind did not survive. But hope is vital, and there are balloons going off in that place just last year. So thank you to the team that helped me, because last week I said to my team, I said, oh my God, I don't know why I picked this topic. I know it's interesting. I have no time to prepare it. So within 48 hours, every one of the team sent me 4 or 5 of those PowerPoints. So I'm indebted to them. So that's what you call connection. And thank you very much for listening. And sorry for going over. Okay, thank you.